Thank you, Speaker. Floor Amendment 2 made a few changes to incorporate feedback from our wonderful Department of Insurance, including reducing the penalty amounts for insurer violations in the bill and making clear that the bill has nothing to do with Medicaid.
Representative LaPointe moves for the adoption of floor amendment number 2 to House Bill 5475. All those in favor say aye. All opposed, nay. In the opinion of the chair, the ayes have it, and the amendment is adopted. Any further amendments, Mr. Clerk?
No further amendments, no motions are filed.
Third reading. Please read the bill, Mr. Clerk.
House Bill 4475, a bill for an act concerning regulation. Third reading of this House bill.
Representative LaPointe.
Thank you, Speaker. House Bill 4475 is known as the Strengthening Mental Health and Substance Use Parity Act. The bill applies to state-regulated commercial insurance, so not Medicaid, not ERISA plans. We heard a lot about that on the floor last night. At its core, this bill is about much better access to mental health and substance abuse treatment by growing behavioral health insurance networks with a front-end mechanism so people can actually use the insurance that they already pay for. We're in a dire situation today where many of us and our kids cannot access timely behavioral health care, like ongoing therapy, like psychiatric care. We can't access it with our own insurance. Why? Some of it is a workforce issue, but on a much more fundamental level, it's about a lack of true network adequacy, even though we have network adequacy laws on the books. Insurance reimbursement rates for behavioral health providers are so much lower than physical health care, and it's a parity issue. Administrative burden for behavioral health care providers are very intense, making it very difficult for them to join insurance networks. It can take 6 to 9 months for them to contract with commercial insurance. So this bill does 5 things to remedy that. Number 1, it sets a minimum reimbursement for private insurers for in-network mental health and substance use care, which is at 141% of the Medicare rate. It allows mental health and substance use providers who are working towards licensure to practice under the supervision of another fully licensed provider, which is consistent with many major insurers today. It requires coverage of mental health and substance use services that happen to be received on the same day, like a therapy appointment and a psychiatric appointment. It requires coverage of 60-minute therapy instead of 45-minute therapy. And finally, it requires a 60-day contracting process when a provider is trying to join an insurance network. Before we go to discussions, I just want to say this is a priority bill of the mental health advocates this year. We've had great ongoing conversations with the Department of Insurance and the insurance industry. And I also want to thank some of our GOP leaders on behavioral health, Rep. Howder and Leader Haas, for being a part of making this bill better. Happy to answer any questions.
On this question, Leader Kiker.
Thank you, Mr. Speaker. Will the sponsor yield?
Indicate you yield.
Excellent. And thank you, Representative. I appreciate the dialogue that we've been able to have. I've got a couple questions, and I think we know where this is going to be. Your bill does some amazing things, but there's some precedent that we're going to be setting in how we deal with health insurance and the rates that we pay. So in Section B, the language requires in-network mental health and substance use disorder delivered by Illinois providers must be the equal to or greater than 141% and 144% of the Medicare reimbursement rate. How did you come up with those percentages?
Appreciate the question, Rep. That percentage came from a very well-respected report called the Millman Report that came out in 2017 or 2019 that really looked deep and looked hard at the ongoing disparity we have between physical healthcare reimbursement rates to our providers and behavioral healthcare reimbursement rates. And it showed an ongoing disparity. And so adjusted for inflation to 2003, we used that report to create the benchmark of 141% of Medicare.
So is there any data on what a primary care physician receives in reimbursement on average versus what you're asking for in here? I mean, just for a regular in-visit, can you share some of that?
Yeah, there's a lot of data showing that the physical healthcare providers, including a primary care physician, are reimbursed at much higher rates than behavioral healthcare providers, even sometimes for the exact same service. So for instance, a primary, like an MD might do a prescription when a psychiatrist gives that prescription or has an assessment, the psychiatrist is reimbursed at a lower rate. And that's part of the disparity and discrimination against behavioral health care that this bill is trying to change.
Let's say
Leader, would you like additional minutes?
I would love,
Leader Davis-Meyer gives you 2 minutes.
thank you. Let's say there's and I'll try to talk faster. I realize we're on a clock, so I apologize. Let's say there's a mental health professional getting reimbursed above this rate with a company that they currently contract with, and that same mental health professional wants to seek out additional contracts with other companies. In those negotiations, the reimbursement rates are the ceiling of what would be offered to that same provider. What would entice that provider to accept the new contracts? Because we do have some providers that are working within contractual groups, and this may actually bring down what they're compensated.
In our bill, the 141% that's outlined is a reimbursement floor. It's nothing to do with a ceiling.
Okay. And so placing reimbursement rates in statute would lock this rate in till the General Assembly visits or alters the statute again, correct?
Correct.
Do you have any concerns about locking this rate into statute and the inability to possibly pass an increase in the future?
I don't, because there's data and lived experience that will, just like data was used to get this calculation of 141%, that will give us a roadmap of where we need to go.
Okay. And I'm going to hop ahead just so I stay in the clock here. While the intent of the bill, again, I praise you on everything but this one part that I struggle with. And I struggle with it because it's a Pandora's box of different types of providers wanting reimbursement rates within statute. We have seen a proliferation of that within pharmacology where we've had minimum out-of-pocket or minimum cost exposures, and with this, we're setting a floor, so we're bringing it up. And I understand the need for mental health services, and they are more so now than ever before. We need to proceed very carefully on balancing the need of affordability for the consumer who, as reported, does not utilize mental health as needed due to the barriers. So we need to be careful with that. But we also need to be careful in creating another unintentional barrier to health care, which is going to be those increased minimum costs. But I want to thank the sponsor. She's done an amazing job of being prepared and working with everybody involved. So I really do appreciate it, Representative. Thank you.
Representative Moeller.
Thank you. Will the sponsor yield?
Indicate your yield.
Thank you. Representative, I know you have done tremendous work in this area, and want to know how this legislation coincides or would fit in with the legislation that we passed yesterday and other bills that are on the floor that have to do with network adequacy.
Yeah, thank you for that. We did have a robust late night discussion on that. So the bills have shared goals. Your bill gets a little bit into the Medicaid territory, and my bill does not. But my bill creates a front-end avenue so people can more easily connect with their behavioral health providers, so they can actually use their insurance and find a therapist or find a psychiatrist in a timely manner. And in particular, we had talked about a lack of access to psychiatric beds, because we know that the bill we heard last night gets rid of prior authorization for inpatient psychiatric. And what my bill will do is create more psychiatric beds by increasing the reimbursement rates for many psychiatrists who are contracting with state-regulated insurance.
Great. So it'll be preventing the need for that or hopefully preventing the need for the acute in-hospital patient care because it'll be giving patients care before it gets to a crisis point.
That is exactly right. I think we all know that access to ongoing behavioral health care prevents acute inpatient situations.
Thank you. I echo the remarks of the previous speaker. Really appreciate your leadership on this issue and happy to support this legislation.
Representative LaPointe to close.
Really appreciate the discussion on this bill. I know everyone in this chamber cares about access to behavioral health. Today we have a situation where about 20% of behavioral health providers, including psychiatrists, have proactively pulled themselves out of insurance networks. They just don't take insurance. People have to pay out of pocket. That just can't stand. We need more parity, and that's what this bill will do by incentivizing providers to join networks. I encourage an aye vote.